So if you're looking at all these ways to define it, I would say that, we're essentially have moved into the endemic stage of COVID. It's here to stay. Our immunity from prior infections and vaccinations is a lot better now than it was 3 years ago. You don't need to shut everything down. We know more about it. So I would say that it's still an issue. People are still dying. People are still getting sick, but it's not having the societal impact as it was even a year ago. So I think it's reasonable to start saying we're moving into the endemic phase of COVID-19.
Hello, everyone, and welcome to Peak Health with Dr. Gupta. This show is for those who want to optimize their health and maximize their genetic potential. If you like our show and want to learn more, please visit our website at peakwellnesshealth.com, which is linked in the show notes below, where you can gain access to a very simple 10-day body reset program that teaches you about diet, sleep, meditation, exercise, and guides you on how to lower your blood sugar, lower blood pressure, lower your body fat, and improve your biomarkers in just 10 days. Additionally, you can find a body optimization module, which teaches you how to lose fat and build muscle. You can also find a link to schedule a one-on-one consultation with me. The COVID-19 pandemic has had a profound impact on our lives, leading to the loss of friends and loved ones and disrupting our routines in ways we never could have imagined. While we are no longer under a mask mandate or a state of emergency, many of us are left wondering if we can go back to our pre-pandemic ways without worrying about COVID-19. Can we attend group events and sporting events? Can our kids go to school without the fear of getting sick? And what about masks and vaccinations? Are they still necessary? To help us answer these questions and more, we are thrilled to welcome Dr. Dost Sarpel to the podcast. Dost will provide us with expert insight into the current state of the pandemic and how we can protect ourselves. Dost completed his internal medicine residency and infectious disease fellowship at George Washington University Hospital in Washington, D.C. He also completed additional training in viral hepatology under the mentorship of Dr. Douglas Dietrich, a world-renowned hepatologist. He is currently the medical director and COO of Capsid Consulting, whose mission it is to enhance the infection prevention and antibiotic stewardship programs in long-term care facilities around the United States via teleconsulting services. In addition to his work with Capsid Consulting, Dr. Sarpel is an infectious disease consultant and director of outpatient infectious diseases with Milford Regional Physicians Group and sees patients at Milford Regional Medical Center in central Massachusetts. Dost and I have known each other for a number of years. In fact, he was my intern many, many years ago and is also a mastermind or is part of a mastermind group where we discuss medicine, current events, and just have fun. If you haven't heard of a mastermind before, it's a great way to use everyone's collective intelligence for a higher purpose. So please look it up. Welcome, Dost.
Hey, Ravi, how are you?
I'm great. I'm really happy to have you join me.
Been a long time. Yeah, I didn't, or I forgot. Yeah. Intern year, probably. You're right.
Yes.
Long time ago.
Yeah, it was long. I still remember when you started intern year.
Yeah.
Your first day of intern year.
Yes.
And really happy to connect with you this way. And it's really nice to see how we all evolve in our own fields and grow and contribute in different ways. And this will be great for our listeners because you can teach them a lot about what's happening currently. And maybe we'll start with a very simple question. Is the pandemic over? Because it seems like it is, the way people are behaving. What are your thoughts?
It's a great question. It's one that, we frequently get in infectious diseases. And I think one way to sort of look at it is what's a pandemic, what's an endemic, what's epidemic, because these terms are sort of tossed around in the media. And it can be confusing, right? So if it's okay, I'd like to take a minute to just kind of
please do
explain the differences, right? So an endemic, it's the constant presence of a disease, usually in a certain region, right? So you could think about, for instance, malaria, right? So malaria, you only see it really in Africa and parts of South America. You don't see it everywhere. And that's mainly due to the vector of disease, which is the Anopheles mosquito. But anyway, it's endemic to that region. So you don't see malaria in Europe, for example. An epidemic is when you have an increase, and it's typically sudden over what is normally expected. If it's limited to a geographic area, it's an outbreak. So, for instance, you can think about Ebola. There have been outbreaks over the years in Africa, in West Africa, where they'll have a number of cases and then it kind of goes away. So that could be an epidemic, smallpox back in the day, when there would be outbreaks of smallpox, even measles currently. There could be outbreaks of measles in unvaccinated populations. Doesn't necessarily have to be an infectious disease. So, you'll hear terms like the obesity epidemic or the opioid use disorder epidemic. I mean, those are epidemics as well. And now a pandemic is when you have an epidemic and then it's in several continents, essentially. And now it's the WHO, the World Health Organization, that sort of will determine when something is considered a pandemic. So they're the ones that determine when something's a pandemic and then when it's now an endemic. So endemic is just this disease is here and it's going to be constant. There could be seasonal variations, but it's endemic. So like flu, it's endemic now. So I would say that, and another way to look at it too, and some people use this definition as the effect on society, right? So when there's an endemic, people are used to living with the disease. Sure, there'll be some sick days, but things aren't going to be shut down for the most part, right? But in a pandemic, it's novel, it's new. Things kind of can get shut down, like we saw 3 years ago. So that's another way to look at it too, societal impact. So if you're looking at all these ways to define it, I would say that we're essentially have moved into the endemic stage of COVID. It's here. It's here to stay. Our immunity from prior infections and vaccinations is a lot better now than it was 3 years ago. You don't need to shut everything down. We know more about it. So I would say that, it's still an issue. People are still dying. People are still getting sick, but it's not having the societal impact as it was even a year ago. So, I think it's reasonable to start saying we're moving into the endemic phase of COVID-19.
Okay. And something that's similar is influenza, right? I guess you could say that that's more of an epidemic. Maybe you can comment on that.
I guess it would depend on the influenza, right? So, there's influenza and there's seasonal flu and we're sort of, used to that, and numbers will increase in November and October, right? But when there's a different type of flu, so like the swine flu, which is H1N1, which was about 15 years ago, 2009, 2010, that was technically, a pandemic because it was novel, it was new, it started, in an area and then it kind of like spread to different countries and continents. So, regular influenza is pretty much endemic, but then there's swine flu now. Your listeners may have read or seen a lot about bird flu or avian influenza because that is what's concerning to a lot of virologists and infectious disease doctors. They've had to call a lot of poultry. A lot of wild birds have died from this current strain of avian flu. There hasn't been any documented person-to-person transmission of it, but people have picked it up from close contact from birds. So that's something on our radar. And if that evolves a little more, that can, maybe jump and form an epidemic. But that is a type of flu. But the regular seasonal flu, that's more endemic at this point.
So basically what you're saying is the pandemic, in essence, is over and has become endemic.
Yeah.
And going to group events, sporting events, school, that type of thing is happening. And we'll talk more about that in a little bit, how to protect yourself. But it's happening. It's just a matter of your risk tolerance.
Correct.
What are these
I
events?
think that's a good way to look at it. Yep.
Okay, great. And we'll talk about more about that in a bit. The other thing I just want to, quick segue into the commonality of these pandemics, because, we're many of us have only experienced this one. And it's scary, but pandemics are actually not uncommon. We talk about the 1918 Spanish flu, but there have been others. So can you just speak to that?
Yeah, actually, they're very, very common, and there have been several in our lifetime. They just haven't affected us for the 3 year plus years as COVID 19 has. But there's MERS, which is a Middle Eastern respiratory syndrome virus. So that is technically by WHO a pandemic that's been ongoing since last 5 to 10 years or so. There was original SARS, so this is SARS-CoV-2, but there was original SARS, which was in the early 2000s. That was technically a pandemic. It just didn't kill or infect as many people. You mentioned the Spanish flu. That's the one that comes to mind because 50 to 100 million people throughout the world died, and the world population was much smaller back then, right? So, when you look at the proportion of people that died, that's the one that jumps out because of how many people died from Spanish flu. And it wasn't just how many people, it was actually young adults. So, we still don't know why, but, people in their 20s and 30s, so it wasn't the elderly, it was people who are, quote, in the prime of their life that died. So that's another reason the Spanish flu sticks out. But, before the Spanish flu, there was something called the Russian flu, which, killed a lot of people. Going back before that, there was, the Black Death in the 1300s to the 1500s, which wiped out about a third of the European population. So there have been many pandemics throughout the history, well, I should say recorded history of humankind. And there'll be more probably in the future for a number of reasons. We know that the vast majority of pandemics come from what's called zoonosis. So it's animal has it, humans pick it up from the animal, whether it's bats or birds or pigs or whatever. That's typically how it's, or rodents or fleas associated with rodents, I should say. That's usually how diseases start and become pandemics because they're novel, they're new to us. The virus or the bacteria mutates in a way that can jump to humankind, and then we don't have the immune system. And we know these zoonotic events, even over the last 10 years, have been increasing. There was a recent study done in Africa that just showed a dramatic increase of zoonosis over the last decade. And there's probably multiple reasons: urbanization, climate change, animals losing their natural habitat and now interacting with humans more. I mean, so there are multiple things at play, and we're coming into contact with them more. So it's just mathematics, it's probability. It's going to happen again, probably in our lifetime. Is it going to affect as many people as COVID-19 or cause as many deaths? Who knows? We can't say for now, but, I suspect that there'll be another one even during my time practicing infectious disease.
Yeah. I mean, that's something that we should all consider when we're thinking about COVID-19. As you mentioned, it has become endemic. We have all relaxed to a certain degree, but these things are going to continue to happen, especially as you mentioned, as we encroach into the ecosystem of different animals, as the climate shifts, as our population grows. I mean, these things are all not sustainable, and
Right.
we can't continue to do these things. And as we continue to do these things, we're going to reap some of these side effects, and one of them are more of these types of infections. So,
And it doesn't necessarily have to be like a new infection. Like, for instance, Lyme disease is now, the tick that spreads Lyme is spreading its territory. So we're, more areas that hadn't seen it are now seeing it, or other viruses like, I mentioned malaria. There's other viruses like chikungunya is another virus. These are vector-borne viruses, so mosquitoes spread them. But as the climate changes, the mosquitoes are starting to travel further and further north. So now we're seeing, when I was a fellow 10 years ago, chikungunya, you had only seen someone who went to like Africa or certain parts of the South America, but now it's like on the Caribbean, and it's slowly moving its way north. So yes, there are the novel diseases like COVID-19 that'll probably happen again, and then there are these other diseases that were sort of located in one region are also now moving into other regions. And so that's the other thing to think about. I know this podcast is about COVID-19, but it kind of all ties together.
Yeah. Yeah. I mean, it's important to consider all these things. It's sort of out of the scope of this podcast to talk about climate change and all these other issues that we're facing. These are super important things to look into personally to try to see how you can help in these types of things. But really focusing on your health, focusing on your well-being, focusing on lifestyle changes can make a big difference for the listeners out there. And that's what this podcast is all about, and how you can help protect yourself, your family, your loved ones the best you can. We're going to talk about that now. And maybe we can start with your own innate immune system, because we all have this innate immune system, which was beautifully designed by Mother Nature to protect us from various types of infectious diseases. And if you've been following my podcast, I've given many recommendations how you can improve your overall health, which in turn improves your innate immune system to some degree. So you may be thinking, okay, well, I'm exercising, I'm eating right, I'm sleeping well, I'm decreasing the stress of my life, and I think my immune system is quite robust now. I'm taking maybe some supplements or whatever I need to take to improve it. I don't need to get vaccinated, or I don't need to wear masks. I'm good to go. So let's think about those things and let's tackle those questions. Let's start with masks. What are the types of masks people wear, and what are your thoughts on wearing masks?
It's a good question, right? And there's a lot of nuance to it, and it really depends on your risk. What risk are you at in developing severe disease? Are you immunocompromised because you're on chemotherapy, or you have some other, or you're on another medication that affects your immune system, or do you have other issues that make you immunocompromised? So your calculation is going to be different than someone who's in their early 40s, doesn't really have medical conditions, and is in good shape, versus someone who's in their 80s, who may have some medical problems, but not a lot, but they're in their 80s. So I think that gets lost in it when it's sort of one size fits all. Everyone wear a mask. You got to do this. In the beginning of the pandemic, 3 years ago, that definitely made sense. But now, as our immunity has changed and as we've learned more, I think it really depends on what your risk is and what your risk tolerance is, and who you're interacting with. Are you going to be around frail people or people whose immune systems are compromised? So that's the main thing you need to think about. We know that good masks worn properly are effective. If you have a surgical mask and you're wearing it below your nose, that's not how you're supposed to wear it. And, it's not going to work, of course. Cloth masks, aren't that great. The gator masks, things like that, they're not that good. Then I wouldn't recommend that. Surgical masks, if you're going to wear a mask, that would be the baseline mask I would wear. And then if you want to go a step higher, there are K95 masks, which provide a little bit more protection. And then beyond that is the N95 mask, which provides the most protection, isn't the most comfortable, but that's what we wear when we see patients who have active COVID. We wear an N95 mask when we see those patients, because we're in an enclosed space with someone who's sick, who theoretically is very infectious. And so that's more of what we need to wear. But in general, I think surgical masks are fine. If you're at a little bit more of a risk, if you want to up it to K95, that's great. There are different ones you can buy on Amazon or throughout. So when I fly, that's usually the type of mask I wear. I think the N95 is too uncomfortable to wear for so long on a flight.
Yeah.
And so I sort of kind of do the middle ground between a surgical mask and a N95 when I fly.
Let me stop you for a second, Dost, because you said a lot of great things there, and I want to just break it down for a bit. So
yeah,
the first is, the question is whether you should wear a mask or not. And how you responded was basically, it depends. And it depends on your risk factors, depends on, how robust your immune system is, it depends on whether there are sick people around you, they're immune compromised relatives that you're living with. And also it depends on the burden of disease in your local community. Because if there's an outbreak in your school, then you want to wear a mask, obviously. Or you
100%. Yep. Yeah, definitely. I may have left that out, but yeah, is there an outbreak going on? Is there a lot? You can check your community level. At least that's the metric the CDC and other state departments of health are using right now. With the end of the federal emergency coming up in May and the end of reporting positive tests, because that's, they base part of their calculation on positive tests. The CDC and your local state departments of health going to need to figure out a new way to track disease burden. And I've heard that they're working on it, and I'm eagerly awaiting to see what they come up with. But that's something you can look at least right now. And in terms of community levels, a lot of places, actually most places, are probably green, which means it's pretty low. So you're probably fine. But
and
if there's an outbreak,
where do you find this?
The CDC Data tracker.
Okay, you just Google that for your local area.
Yeah, if you go to CDC Data tracker, a drop-down menu comes up, and you can click on the county. There's also a map that's on there that you can zoom into your county as well, and it will give you the numbers. And green is low, then yellow and red, and they have different recommendations for each. We consult with schools and other businesses, and we've been saying for a while now that when it comes to masking, we like to connect it to community levels. So if it's green, fine, you don't need to mask. If it's yellow, you could suggest it, recommend it. And if it's red, then okay, there's high levels of disease, and maybe it'll be a good idea to wear masks in an enclosed setting. So that's one way to kind of look at it. I would say right now, most communities are in the green, and if you're not at risk, then, I don't think you necessarily need a mask in most cases.
And the other aspect to consider also is if you personally have some kind of respiratory infection, viral infection.
Sure.
Doesn't have to be SARS-CoV-2, but,
right.
else, it's a good idea to wear a simple surgical mask, because that
or stay home. Yes.
Yeah.
Or stay home.
Stay home,
I think
go outside.
Right. We have this, our culture at least is to show up to work, and there's a lot of reasons for that. But even when we're sick, we got to go to work. And if you're infectious with COVID or flu or RSV or some other virus, really be best to just stay at home, recuperate. Then you don't run the risk of infecting other people. And then, even if you're feeling a little better, but you're still kind of sick, wearing a mask. That's not common in the American culture, and hasn't been, but it has been in, other cultures, like in Asia, they're during flu season or whatever, they wear masks. I mean, that was just part of their culture that we here in the States didn't have. But, if you're sick, stay home. If you have to go out and you're sick, wear a mask.
Yeah. Thankfully, it's becoming more commonplace for people to do so. It just reminds me, I was at the gym the other day, and this girl walked in and just coughing constantly, no
Yeah.
mask, and it's not like she was coughing her lung out. And I'm like, this. First of all, she shouldn't be at the gym.
Right.
Secondly, at
Yeah.
least she should be wearing a mask. And it was just, I just stepped away from that area. But if not, you're really not wearing that mask when you're sick for yourself. You're wearing for other people.
Yeah. At that point.
Getting the
Yeah.
spread to those people. That's something to definitely do. So there's the different types of masks. The simple surgical mask that you mentioned. Makeshift masks, which really aren't recommended.
Not really. No.
Yeah, and then you said the K95 and N95. What's the difference between those two?
One is vetted by the FDA and OSHA and other federal institutions here in the States. So that N95 is sort of what's approved here. The other ones are typically from Asia and, maybe approved there, but they, for whatever reason, haven't been approved by the FDA for the purposes of an N95. So that's usually the major difference,
Okay.
really, because they just don't do the experiments that need to be done to differentiate the two.
Okay, and
So,
these masks, and they're made of the same material, the K95 and N95?
I believe so. Yeah.
Okay. So these masks are tighter fitting masks.
Yes.
They prevent the small aerosolized particles from being inhaled, whereas the simple masks don't. So that's
Yes.
certainly something to keep in mind that, if you're wearing a simple mask and somebody has an aerosolized infectious disease like SARS-CoV-2 or COVID-19, that simple mask isn't necessarily going to protect you. You'd want to wear an N95 mask. So those are the different types of masks. So really, it would be K95 versus simple face mask. When you travel, you say when you're on a plane, you wear
So there's
95.
yeah. So it's actually I'm gonna double try. I think it's technically a K94
Okay.
that I wear.
Well, that makes a big difference.
It makes a little bit of a difference. Yeah, yeah. So I was just making sure. So it's not quite at the 95 level, but it's still a lot better than a surgical mask, and they're
Okay.
pretty comfortable. But what you were saying before about aerosolization, that's actually an important point. What we've learned during COVID-19 pandemic is, we used to say, oh, flu is droplet, meaning it's in heavy droplets. It doesn't stay in the air for a long time. It can't travel, right? Versus something is airborne. So, for instance, tuberculosis, where it can like hang out for a long time, or even measles and even travel. And there was a lot of, I'm not going to bore your audience. There's a lot of scientific debate when the SARS-CoV-2 pandemic first started. Like, is it droplet? Is it airborne? So now we've realized it's probably a spectrum. It's not black and white the way we used to see things. So in certain settings, COVID-19 or SARS-CoV-2 can be airborne, can be aerosolized, and can cause significant disease. So there have been outbreaks, for instance, in church choirs, because they're in a sort of enclosed space. So the person who has COVID-19 is singing, spraying everything out, and it kind of hangs out and then can infect someone. There have been studies done in restaurants that have shown some people are sitting like right here, and then people like all the way across the room got COVID-19. If it was droplet, that wouldn't happen. Well, why did that happen? And we're going to talk about airflow, I know, later, but it's like these people are by an air vent that it's like pushing, and then the particles, the SARS-CoV-2 is able to stay airborne, and then these people across the room got infected. So, yeah, there are certain circumstances where it can be aerosolized and be considered airborne, which that is why we wear N95s when we're in high risk situations, right? In an enclosed space with an actively infected person who is coughing, then, we're going to be wearing an N95 in that setting.
Okay. Well, let's jump to that. Let's jump to air quality and ventilation, because that's, that's also an important consideration, because if you're outside and you're, in a group, there's much less risk than, if you're indoors in a closed area with poor ventilation. So
Yep.
maybe you can comment on that.
Yeah, definitely. So the mantra throughout the COVID-19 pandemic is, outside is always better than inside. So whenever possible, be outside. That'll be greatly reduces the risk and for contracting COVID-19 as well as other respiratory viruses. If you are indoors, opening the window, making sure there's great airflow, air exchange is huge. Those things we're now realizing are very, very important. And it's becoming more on the minds of people who work in public health, right? So cholera used to be a huge problem throughout Europe and still is in some circumstances. But in London, there'd be like cholera outbreaks every summer, is because they didn't have a sewage system at that time, so everyone would just be exposed to human waste. And then they developed a sewage system, and then the cholera outbreak stopped. And then this led to, the modern day view and control of food safety and sewage safety and things like that. Well, so that we've sort of tackled. And then now we're realizing, well, public health, public space, air quality, that's sort of the next frontier. And it's not just about COVID-19. It's about other respiratory viruses, flu, RSV, parainfluenza, Haemophilus, and any other ones that are out there or will be out there. We know that having better air quality reduces disease burden. So being outside, having windows that are open, air filtration, what is your level of filtration? So, you can check your filter at home or in your office building. The guidelines are for at least a MERV 13. If you're in a big public building, maybe in your house you have a MERV 10. I know in my house we have a MERV 10, which is good, but not as good as MERV 13.
But that's not an HEPA filter. That's just a standard filter, correct?
No, that's just a standard filter that's in your HVAC. So that's one thing you can do is, can your HVAC system handle a higher level filtration? A lot of times in the older buildings, they can't, because then you need to increase the power of the fan, and it may not, your HVAC system may not be able to handle it. So there is a limit to how high of a filter you can go on your HVAC. So that's one thing, that you can do and look at. As you mentioned, HEPA filters are something separate from your HVAC, and there's been a huge increase in the different number and types of HEPA filters. So there are smaller ones that are good for, so basically you just need to know the size of your space, right? So if it's a small little office, you can get a smaller HEPA filter. If it's a bigger area, then just get a larger one. I mean, there are different types out there of varying qualities, but HEPA filters are very important, especially if you're in a building that the HVAC system can't really, be upgraded without being completely replaced, which, I get can be, the logistics of it can be difficult. So you can do HEPA filters, which we do recommend. Beyond HEPA filters, there are other things you can do. Healthcare facilities often use UV light. That's another big one. So you can either have them installed in the room, or there are portable UV light systems that have been shown to decrease viral burden. And then now there are companies out there that it's sort of ionization of the viral particles that reduces the number of the pathogens that are in the air. And there are different ways for this to work. They can actually install it into your HVAC. You can install it just into in a portable area like a bus. I know there are some public transportation systems that kind of use that. So you can put it in a bus, or, if it's a small clinic, you can have like a small stand in that clinic. So there are ways to improve air quality that we're starting to learn more about and utilize more. And then there's also more thought in airflow, right? So you want better airflow, but if you're putting up huge barriers or the way a floor is designed, if it's really limiting airflow, like whatever, if you're limiting it due to the way the wall is shaped or things like that, then that can reduce the airflow, reduce air exchanges, increase or worsen the quality of the air in that room.
Okay.
So that's another thing we're looking at too.
So to sum it up, air quality, ventilation, very important. The gold standard is really being outside.
Yes, that's
Lots of
true.
airflow. Yeah, lots of airflow, lots of fresh air. And in fact, being outdoors not only
UV light.
helps, yeah, UV light, exactly. Not only helps with that, but also just kind of just generalized feeling of wellness. It's important to get outside as much as possible. But if you have to be inside, really pay attention to these things, pay attention to airflow, pay attention to HEPA filtration, I think is incredibly important, especially if you're in an area like in a city or where there's a lot of cars passing by, because not only will it filter some of these infectious particles, but the microparticles and smog and things like that, which can cause allergic reactions or trigger asthma or something to that effect.
Sure.
It'll help with that. So,
yeah, most definitely.
Yeah. So, excellent. So let's now shift to vaccines. Oh, wait, before we do that, you say you wear that K94 in an airplane. Personally, I have, and this is just a personal choice I have, because I'm so fatigued wearing masks, and I've looked into the air filtration in planes, and half the air is filtered through a HEPA filtration. Half of it is from outside, where you're at 30,000 feet. It's clean air, and the way the air flows, it flows through the aircraft in 2 minutes. I mean, it really cycles the entire aircraft in 2 minutes. So I personally don't wear a mask in a plane. That's just a personal. I'm not saying do that if different situation. But that's what I do.
I agree with you. The air quality on the plane is probably amazing because of everything you said. The caveat is, like, if you're next to someone who has COVID, that's not going to help, right? So if they're sitting right next to you. But in general, you can't really find indoor air quality better than what is on an airplane. That's true. But also, I realize, presumably you're on a plane because you're going on vacation. So you wear a mask, not just, to me, it's like, okay, I wear a mask for a few hours. It reduces the risk of me picking up anything, not just COVID-19. So then I can enjoy my vacation.
Yeah. So that's the way. You eat the peanuts on it that they serve you, Dost, them on the aircraft?
No, actually, not when I'm masked. I don't. No, I don't eat or dry. Oh, yeah. No, I just keep the mask on.
Keep it on? Okay.
Assuming it's a short flight. Yes, obviously. I don't think I've been on a long flight since COVID. So for 2 to 3 hours, I'll just wear the mask. If I'm on a 10-hour flight, it's a different calculation, of course.
So you not only are preventing infectious disease, you're also helping with obesity because you're not eating crappy,
exactly.
Crappy airline food.
Exactly.
Okay, so now let's shift over to vaccines. Because people also have this question: should I vaccinate myself? What are your thoughts on the vaccines? Now, how do they work, and what are your thoughts on the vaccine?
Sure. So the short answer is yes, you should at least get the primary series. So, and the way that most of us look at the primary series is 3 shots. So initially, when the vaccines were developed and then approved, and we started giving them out, it was 2 doses. Initially, 3 to 4 weeks apart. And then in some cases, you could go a little bit longer. But you have to remember where we were at that time. It was the middle of the pandemic. People were getting sick. The hospitals were overrun with these sick patients. And we're, trying to get we got the vaccine out, and we know that we knew it was safe. We know it's still safe, and we know that it provided protection. And then we followed people, and then we're like, oh, giving this booster dose a few months later after the last one, that really seems to protect people more. And that, I would say, came to the forefront during the Omicron wave, especially. So the first two doses were very protective for Delta, and then the original and Alpha, and it's very protective. Then Omicron came. It's like two doses weren't as protective. You give them a booster, and it was really protective. So the way I look at it is primary series is 3 doses, and then moving from there, do you need a booster? Again, that is dependent on your risks. So even now with the new variants, BQ1 and XBB, the original 3 doses are still pretty protective against severe illness. So like hospitalization, very protective against that. Still, like, not as protective as it used to be, but I mean, it's still a decent amount. That 4th dose, or second booster, definitely provides protection for the first few months, 2 to 3 months. It provides really robust protection against getting an infection. But after that, the protection gets infection wanes. And there is some evidence now, people are looking at, the new bivalent booster versus the original monovalent booster. And is it actually better? Again, it depends on the risk. So it's definitely, if you're older, so if you're older than 65, or if you have a number of medical conditions, lung disease, heart disease, being overweight, diabetes, things like that, or if you're immunocompromised, then yeah, most definitely we know that the bivalent provides much better protection against severe illness versus, just the original 3 doses. But if you're 25 and fit, healthy, is there still, what is that delta in terms of the protection that the bivalent vaccine provides? That we're still trying to tease out, because we know the original 3 doses of the monovalent still is provides protection against hospitalization and severe illness, which from an infectious disease standpoint, that's really the end game, right? So vaccines in general aren't to prevent infection. People are going to get infected, but they're there to provide protection against severe illness.
Yeah. I want to stress that point you made, because that's where people don't understand when we talk about vaccines. It's not to prevent the illness; it's to prevent the severity of symptoms. That's an extremely important point. And when people get a vaccine and then they do in fact get COVID-19, they're like, oh, that didn't work. Well, it's working to prevent you from getting more sick than you are at that time.
Exactly. So it reduces hospitalization. Again, it depends on the populations you're studying, but if you're looking at vaccinated versus unvaccinated, it reduces hospitalization by 80%. And it also, we're finding, at least, it reduces the risk of long COVID if you've been vaccinated. So I definitely would say that everyone should at least get the primary series of vaccine for sure. And then, do you need a booster? How many boosters you need? I think that is dependent on what are your risks, and a conversation you should have with your medical provider.
Say you're 45, 50, no other comorbidities, you're otherwise healthy. Would you recommend a bivalent booster to that group?
Probably. I'm not saying I would not recommend it. If they want the vaccine, sure, it will provide some protection. But that is not the group that I'm going out being like, you absolutely 100% should be vaccinated. The group that I'm saying that to are, the 65-year-olds with diabetes, that we know you really need to get vaccinated. Or my parents, for instance, who are in their mid to late 70s, those are the people 100% should get vaccinated.
And if you do meet criteria for that bivalent booster, how often should you get it?
So right now it's just the one dose of the bivalent. There are studies that are ongoing and discussions that are ongoing to see if it should be yearly, maybe every fall. They're looking into combining it with flu. So like you get COVID and flu vaccine in one shot, so those things are being looked at and studied. And it seems that the experts are sort of leaning towards a yearly vaccine, especially for at-risk people. But that's something that we're still trying to work through. I mean, I understand people have COVID fatigue, but in the grand scheme of things, it's only been 3 years, which, we're gathering data, we're gathering it as fast as we can, but 3 years in scientific terms is not that long of a time. It takes us a while to figure out vaccine schedules, for instance, for shingles or chickenpox, or do you need a booster? Well, the way we figure that out is like, oh, wait, 10 years after the original vaccine, people are starting to get sick again. Like, oh, maybe we should boost them. So we're still trying to tease this out. Right now, the recommendations are for yearly at least for at-risk people, which includes pregnant females, by the way. So they're at risk as well. And a thing I would also add about pregnancy is there are a bunch of studies now that show that if you get vaccinated when you're pregnant, the likelihood of your infant getting sick decreases dramatically. There's protection that passes on to your infant. And it lasts. So then now the vaccines are approved down to 6 months. So, pregnant mother, you get vaccinated, then your infant's protected. And then at 6 months, they can get the vaccine. So that's something to look at. Again, for a healthy person that you mentioned, I'm not 100% sure that they absolutely need the booster. The original series, the 3 shots, definitely without question. Beyond that, I think we're still trying to figure that out.
Final question. I know you consult in the hospital often. You see these patients with COVID. We both worked in the hospital wards back in 2020 where, it was original strain of SARS-CoV-2, and that was much more severe. We didn't know what we were doing in terms of therapeutics. What are you seeing as far as deaths from COVID currently? Are the therapeutics good enough such that, most people, barring the severely immune compromised and elderly and that type of cohort,
Sure.
are doing well? Are they surviving?
Right. So I think that is a great question. And, people are saying like, oh, Omicron is mild or the new variants are mild. Well, actually, it's not. It's just as severe as original strains. The difference are, one, we have baseline immunity, right? So over 95% of people have either been vaccinated or have had COVID at least once. I will say to your listeners that, yes, having COVID before is protective against severe illness from a repeat infection. That doesn't mean you shouldn't get vaccinated. There's a concept called hybrid immunity where you combine, you have the previous infection and then you have the vaccine, or you get vaccinated, then you get infected. It really enhances your immune response. So even if you've had COVID before, I still would say get vaccinated because we know that those people do better. And again, there is some data suggesting some data, right? Synergistic, good way to put it. And there's data suggesting it reduces the risk of long COVID as well. So even if you've had COVID, I would still say get vaccinated. So anyway, that plays a role. So now we have more baseline immunity. So that's one. Two, we have a much better understanding of the disease process and how to treat patients and isolate patients and prevent the spread of disease. So yeah, the therapeutics are excellent. They reduce the risk of death and severe illness and hospitalization by anywhere from 70 to 80%, depending on the therapeutics you're looking at. So Paxlovid is the best one. It reduces risk by 80%. Remdesivir is almost as good. The difference with remdesivir is it's an IV medication. The logistics of it are difficult because you have to give it for 3 days. But if you're near a hospital that has outpatient clinic that can do this, then that's great. So, for instance, the hospital around here is UMass Memorial Medical Center. They have a outpatient remdesivir clinic that a lot of the smaller hospitals in the area will send to get treated. And then molnupiravir is probably the third one. That probably reduces your risk by 30 or 40%. So it's not as good, but definitely the deaths are lower because our therapeutics are better and people have baseline immunity. But, if you're at risk because you're 75 and have 10 medical problems, sure, we can reduce your risk, but that risk is still there. And then the timing is important. That's the other thing we've learned is, getting people on these medications sooner rather than later is extremely important. And that's something we've learned over the last 3 years and we've gotten better at. So those are the way I look at it. It's not that the actual virus is getting milder. It's that, one, our immunity has improved through infection and vaccination. Two, the therapeutics are now available, and we, as physicians, know how to utilize them better than we did before.
Okay, Dost, this was phenomenal. You really answered the questions about masks. You answered the questions about vaccines. And, there's some listeners out there that are very healthy that may opt to not wear a mask and should get the, initial series, but not get the booster. And that's okay. That's okay for them. But I think you really have to understand that it's not just you that you're thinking about. You're thinking about your friends, your family, people around you. So consider those things when you're making your decision. I think also what is very important is understanding the basics of a healthy lifestyle. And we've stressed this on this podcast series, but just to repeat, plenty of sleep, exercise, nutrition, stress reduction, reducing exposures, and reducing exposures by wearing masks, reducing exposures by getting outside. Those things are super important.
I definitely agree with that.
Yeah, absolutely.
Yeah, no, I was just going to say, I agree with all that. We may not have it, at least I can't recall if we have the data for COVID-19, but there is data out there that, people that have a healthier lifestyle actually get a better response with the vaccine, like meaning that they produce more antibodies. I mean, that's been shown with flu vaccines and any number of vaccines, and extremely important in terms of living a healthy lifestyle. We also know that if you're sleep deprived, your risk for getting more severe illness is increased. So healthy, being healthy diet, sleeping well, exercising if you can, all those things actually improve outcomes, whether it's COVID-19 or some other infection. So definitely can't stress that enough as well.
Very important concepts. I'm really glad that, medicine is starting to see this too, because studies are becoming more common in these different types of areas. And we see it, from a scientific perspective, but then also we've known it, just in our cultures and our communities for many, for many generations, that these things are really important, but the science is now supporting it. So awesome, Dost. Thank you so much.
Of course.
Nice to have you on the podcast.
It's great. I'll come back anytime. Let me know. I'll be here.
Appreciate it. I hope you enjoyed this podcast. And if you did, please make sure to hit the subscribe and the like button and leave a comment about what you'd like to see on our future episodes. Just a reminder that this podcast is for educational purposes only. It does not substitute for professional care, nor does it constitute medical or other professional advice or services. If you're looking for medical care, please seek a qualified doctor or medical professional. For more information, or if you'd like to check out our programs, please visit our website, peakwellnesshealth.com. That's peakwellnesshealth.com.